Hi, everyone, and welcome to our 2021 Self-Direction Virtual Conference Series. My name is Casey DeLuca, Director of Membership and Conferences for Applied Self-Direction. Thank you so much for joining us today for what is my favorite session title, From Snap Bracelets to Smartwatches, Paid Family Caregiving Research Over the Years. I'm going to run through just a few quick housekeeping issues before we begin. You can submit your questions and comments at any time during the session by using the Q&A pod in the lower left-hand corner of the Adobe Room. If you experience any audio or technical issues during the session, you can send us a message, again, by either using that Q&A pod, or you can also email us at info@appliedselfdirection.com. I am so excited to introduce our speakers for today. We have a panel of researchers, including Merle Edwards-Orr from Applied Self-Direction, Ellen Mahoney from Boston College, and Lori Simon-Ursinowitz from the University of Maryland. We also have Carrie Amaro from AARP with us to moderate this session. So with that being said, I will turn things over to Carrie to get us started.
Hi, everyone. Yes, I love the session title, too. Thank you, Casey. So I am Carrie Blakeway Amaro from the AARP Public Policy Institute, which is AARP's think tank, kind of. So we also do research, but certainly our research is used by the rest of the organization, AARP, to advance the interests of our members. So caregiving and family caregiving has always been a priority topic for AARP for a very long time, and we at the Public Policy Institute have collaborated with lots of organizations to do research in the area. Several reports that you may be familiar with, including Valuing the Invaluable and Caregiving in the U.S. Those are just a few. I also noticed today that Nancy Lamond, who's our Chief Advocacy and Engagement Officer at AARP, just published this morning kind of a thought piece about how important it is to make some pretty drastic reforms in long-term care, and she named these 5 steps that she thought were really critical and that AARP would support, and one of those is to increase support and financial compensation for family caregivers. So that certainly is in line with a lot of what we're going to be talking about today. Of course, the idea of paying family caregivers is not new, which is one of the things we're going to be hearing about is some of the history of it. It kind of goes back a long way, but the reasons for doing it, are really varied. I'm not sure that it necessarily started as a way to, to think about reimbursing the economic value of the care. I think it really came out of the idea that individuals with disabilities and who are needing supports and services should have the right to direct their own services, which is, of course, self-direction. And they should have the right to hire anyone they want to be a paid family caregiver. But of course, there are lots and lots of good reasons, why paying family caregivers is a good thing. And we're going to hear about, some of the research that's been done over the years, going pretty far back. We're really excited to hear the history. And then also hear about what's happening just in the last year, because COVID, of course, really has shown a spotlight on some of the major problems with the long-term service and support system. And while the idea of paying family caregivers, is not as widespread as we would like it to be, there's growing interest. Particularly just because of COVID, you think about how important it is for people to be able to stay in their own houses with their own kind of family pods and not have people outside that unit coming in and out of the house for infection control reasons. But there's also, this year that the shortage of direct service workers has really gotten worse, and compounded by the fear that, rightly so, and the concerns that workers have of going in and out of people's houses during this time. And then, of course, for economic reasons, family units really need financial support. A lot of the family caregivers in this country that may have been working outside the home lost jobs this year and don't have other, income sources. So the idea of, supporting the entire family unit in a way that supports the person with the disability or the older adult, as well as, the rest of the family, makes a lot of sense. So I'm excited to hear what these researchers have to share with us today. And I hope you guys will participate and ask lots of questions. Please feel free to type them in at any time. We will probably save them until the end and have a chance to then ask our speakers and have a little bit more of a discussion through the Q&A that Casey mentioned. So I'm going to go ahead and turn it over to Lori to take us back to some of the early research that she did in this area.
Thank you so much. I am very excited to be here today, and as Carrie mentioned, this has been a very large part of my career, going back to my dissertation, and so just the fact that there's so much renewed interest. You can see from my subtitle, Everything Old is New Again. I could have also called it a trip down memory lane, and that's really what I'm going to do. I'm going to invite you all to do this trip down memory lane with me to talk about the history of this, I think, very important policy option. So in the few minutes that I have, I'm going to get this point across that this is not a new policy and why it's important to know the history and some key reasons why people either support it or don't support the policy, and then just mention some of the long-standing programs and go into more detail about the cash and counseling demonstration and what we found about paying family caregivers. So why is it important to know this? First of all, policymakers have very strong feelings, either, and this has been over the years, either they really love it or not so much. And the decision making has been based on worst fear scenarios. And now we do have a substantial amount of research that the findings can actually replace the policymakers' worst fears. And we want that. We do not want policy made on worst case scenarios. And so just some of the major views from people who think this is a very important option and support it, and then also some of the concerns. So the people, they believe that participants have more ability to remain in the community by empowering participants, and of course that's what this is all about, and providing improved quality of care. And this is based on the assumption that caregivers, people who are related, love the person and care about them a lot and know that person very well. Now, all of these views reflect people's views about families. And as we know, families are all different. Some are very functional, others not so much, and everything in between. So we need to keep that in mind. It also can stretch scarce resources, expand the worker supply, and we know that that's been a long time national problem and more so in COVID, and increase participant choice and decrease caregiver burnout. So some views about people who, from people who don't support this, they are concerned about a lack of training, and so the worry about high quality care, and very often the concern comes up about, this is very stereotypic, but the drug addicted son who's going to go off with the money and not provide the care. And so along the line, concerns about fraud and abuse, which just as I'll give you a heads up, did not find that, no research to support that, and concerns about the impact on cost, about the woodwork effect, which is a phrase that refers to people will come out of the woodwork because it's such a positive, attractive option. And underneath all of these concerns about cost is an underlying question that has not been settled in this country yet about what is appropriate family government responsibility when it comes to caring for older people. And next, some of the concerns, a little bit about some long-standing programs that have allowed family caregivers to be there we go. Having just a little sluggishness in moving the screen. So we'll mention a little bit about a program, longstanding programs in Illinois, the Veterans Administration Aid and Attendance Program, the largest longstanding program in California, and then cash and counseling. So starting the trip down memory lane, you can take this trip with me. So this is starting in 1985. Nathan Linsk at the University of Illinois led this project, and it was funded by the Illinois Department on Aging to look at this policy option, and I was very fortunate to join this team, and this became my dissertation. And I will just mention that Jean Blazer, if anyone's on the phone from Illinois and has been around for a long time, you'll know she was the director for a long time. She was not a fan of this program. And this program's been around since 1979 and did offer this option. And a book came out about this project, and this is just in terms of, so you know, some resources about this. And in 1998, a special issue of Generations looked at ethics, and there was a counterpoint about this option, and Jean Blazer wrote the counterpoint, why it should not be allowed, and I was able to write the piece on why it should be an option. So that was kind of fun. Next, the Veterans Aid and Attendance Program. I learned about this when working with Paralyzed Veterans of America, and this has been a long-standing program since 1955, where veterans and their spouses who are older are given a tax-free benefit. They can use it for any purpose around personal care, long-term care, and there's the option of hiring relatives. And then this long-standing program in California, some names to know here are Catherine Keatsman and Ted Benjamin are people who've done research in this area. I just want you to know about the names and the resources. And this has been a long-standing program since 1974 and has always allowed family caregivers. And next we have the cash and counseling demonstration and evaluation. And I'll just give you enough information to understand a few of these findings. But one of the early articles was about supporting family caregivers and options that should happen. And there was a special issue of Health Services Research reporting on all of these findings and specific articles about families. And if you want some very in-depth stories and ethnographic study that really gives you a feel for what the life of people in this program were like and their families. And that really spoke highly to policymakers. So in 2010, we had a session and a special issue in the public policy report looking at what research tells us about this policy option. So it was an update on all of the findings. And just very briefly, I'm just going to give you some headlines. This was a large demonstration and evaluation that compared a consumer-directed model of providing home care with an agency model, and it became a story of people hiring their relatives because at least half did. And so people were concerned. What we found was that increased quality of care, and so now some of the headlines, people were more likely to receive care versus those who were not able to find someone to hire and went without care. They were less likely to have unmet personal care needs. They were more satisfied with their overall care. They had the same or fewer number of adverse health effects as those with non-relatives, and they were more likely to be satisfied with the way they were spending their days. And so, in short, we can see that there is lack of research to support concerns about fraud and abuse. It really just was not an issue. And people who are hiring relatives were less likely to say that the caregiver neglected the patient, consumer. And finally, in summary, we see that the policy implications are increased access to care, increased quality, caregivers benefit, and states learned how to control costs. Initially, some of the costs were greater because there were more people getting care as opposed to going without. And in conclusion, we can see that the research findings from this very large study, about 6,500 people across 3 states, support that this should be an important part of long-term care policy, and research can replace some of the long-standing fears that have guided policymakers in moving forward, can help make some tough budget decisions and informed decisions about implementing home and community-based services that is supported by some of the new national infrastructure funds, and also address renewed policy interest during the pandemic based on long-term care shortcomings that we've seen. And next, we will hear from Merle.
Thanks, Lori. Yeah, I was wondering, actually, Casey, before we get too far along, could we take a look at the first poll? This is going to be, I'm going to get a little wonky every now and again. Not very, but could we, the first poll we had up, who we got here today? Is that, can I take a look at that one?
Sure, yep, let me grab it real quick for you.
Great. And then I'm going to give you another one. But I'm just wanting to, I know you all took some time to fill it out, and I didn't get a chance to see the answer. So while we take a look at that, great, what do we got here? Okay, so we're pretty evenly split between state and, okay, we're mostly state people. Okay, good. Then I don't get wonky when I get wonky when they like, I won't lose you. FMS folks and some family members. Okay, great. So I'm going to try to not get too crazy here. That's helpful for me to know. So while I go, we'd like to take a look at, I've got another poll for you, which we can put up there and have folks respond to while I talk quickly about the agenda. What I really want to look at here is just really kind of the status of where we are right now. And actually, the right now changes by the minute, of course, with the initiatives that are coming out of the new administration. But right now, as best we can define it. But I want to do that by really talking a little bit about what happened in the last year, how that really brought some issues to light. Now, then go backwards, talk about what things were like, in February of 2020. And then talk about how things have changed as a response to the crisis. I see we're getting some results in right now, and we're seeing that about 3/4 of the folks that are here have, even more than that, are allowing. Why don't we just close the poll in about 10 seconds? But we see that basically. It's about 3/4 of you live in states which allow spouses, parents, or guardians to be paid. So that we're seeing that, in our group today, paying caregivers is fairly common. We're going to find that's not necessarily true across the country, but we have a privileged group here. So, or at least for those of us who walk into this thinking that paying family caregivers is the right answer. So, with that done, thank you so much. Let's start talking a little bit about what's happened. What things were looking like going into the pandemic. And speaking of research, these data, and really going with a bow back to Carrie, most of this information comes from work done by AARP when they did some fairly significant studies of family caregiving over the last several years. They found out that there are almost $500 billion is the value of family caregiving. That's real money. We talked a little bit about the worker shortage. That the worker shortage is only going to get worse. So it's going to grow. That's going to grow more. That's a job category than any other. Look at all the Department of Labor stuff. And the family caregivers are going to be increasingly required to meet the needs as we have this increased need and problems with the workforce shortage. And of course, in the last year, the workforce shortage situation has gotten worse, as Carrie alluded to. But so simply that it's not been safe. Parents have had to stay home with kids, and so therefore they can't go to work. And unemployment compensation, and I say, people are talking about this like it's a bad thing. I'm not sure it is. Unemployment compensation has been enough to actually, for folks that they don't need to go into situations which are dangerous and unhealthy for themselves. And that has actually, I think, been very supportive of many families, just often not families of folks with seniors and folks with disabilities. I think the other thing that's crucial, and we've talked a lot about this, but it's really important to remember what a crisis this has been for nursing homes. And I think a lot of what has really spurred the Biden administration to make these initiatives around home and community services is looking at the situation that the COVID pandemic has brought on nursing homes. The latest toll, and these figures change, and actually, interestingly, have tapered off to some extent recently, but that almost 40% of all deaths from COVID are for folks in nursing homes. So out of 5% of the total cases. So that this has been a devastating event for folks in nursing homes, and have really brought very much into focus the question of what are we doing here and what's the best way to care for folks who need care. Obviously, then therefore taking a second look at family caregivers has become an obvious answer. If we have a worker shortage, we don't want to go to the nursing home, then where are you going to go? And where you're going to go is looking at folks who are already in the situation. And it makes a lot of sense, like Lori had already talked about, so I don't really need to talk about this at great length. Let's talk a little bit about what the situation looked like. Would be in 2019, almost exactly 2 years ago, when we did the National Inventory of Self-Directed Programs. And at AARP's request, we looked at a couple of things. First of all, what programs that had self-direction explicitly allowed had respite as a service, so that if you were self-directing, would respite be a service that you could self-direct that was recognized as part of a service plan or not? And the second question they asked was what were the restrictions on family caregivers, and how many programs were restricting family caregivers? And so what we found, and the figures are very interesting, which is why I had to go and take a second look at them, is that we found that about 140 out of the 260 self-directed programs had respite as a waiver service. Now that matters in this context because it says at least those almost just over half of the programs are recognizing the role of the family members play and are trying to support family members as they deliver services. They may not be willing to pay them, but at least they're going, okay, we got to take these guys into account. Then we find almost the exact same proportion, 144 instead of 141, programs had some sort of restrictions on paying caregivers, which is to say spouses, parents, or guardians would not, in some mixture, maybe only spouses, maybe only parents, were not allowed to be paid family caregivers. It needs to be noted that many of these programs had some kind of an appeal structure, where if you could prove that the family member was the only person who was available, which in rural areas is not at all uncommon, or that the family member had certain skills that nobody else possessed, which for folks with really high needs can be the case. But generally, walking in the door, the assumption is that we're not going to be paying family caregivers. Interesting. So I took a look and said, okay, what's the overlap here? And what we find is we've got 56 programs that, to me, from this would be the kind of maximally supporting families, which is to say they recognize respite as a service, and they had no restrictions on paying family caregivers. But that's only about 20% of the total programs. We beginning in 2019. Are really saying, yeah, we need to take families into account, and how are we going to support them to a kind of maximum level according to what the information that we had available to us. So what do families think? Again, going back to some work that AARP has done, we find that it really varies between a majority and a vast majority. Families think that the caregivers of adults think it would be helpful to be paid, that they're reporting some real strain and their financial strain, and therefore getting paid would be helpful, and especially in high-intensity situations, feeling a real need for pay. And I think that a lot of this is, to me, the issue, and again, Laurie's talked about this somewhat. The issue also is the kind of contradiction. If you've got to pay the rent, that you then have to leave the house, turn the care over to somebody else so you can make money to pay the rent. That's a contradictory situation for families to find themselves in. So what has happened as a result of what's happened in this post-COVID era and the during COVID era? And the big issue to look at really for the immediate response is what is known as Appendix K. Some of you are probably familiar with Appendix K, but it's an appendix of the Social Security Act in the Home and Community sections of the Social Security Act and the Social Security Act in general, which says if you need to change a program in the face of a national emergency, you can do it. You can make emergency amendments to your program in the face of an emergency. And since an emergency was declared because of COVID, this allowed for states to fairly simply make these changes. And one of the changes that they were allowed to make fairly simply was to permit the payment of services by family caregivers or legally responsible adults. Spouses and parents and guardians are often lumped together as legally responsible adults. And CMS allowed states to do that relatively simply. So what happened? And let's take a look at this map. First of all, an important a limitation. This is looking only at programs that are serving folks with physical disabilities and seniors. So folks with developmental disabilities and other programs aren't showing on this, and that's going to matter later on when I talk a little bit later. But if we look just at that subset, what we see is in walking through these greens, and you need to know I'm a tiny bit colorblind, so these greens get a little weird to me. But that we find that the dark green states are the states that are saying, yeah, going into this, they allowed families being paid. So a fair number of states did. They had the middle green color are the colors of the states that made changes. That said, okay, we're going to now support. We're going to allow, as part of the appendix pay process, to do family caregiving, and that's really the key group we want to look at. So we can see that a fair number of states took advantage of this process, which says, yes, we're going to allow for the limitation, recognize the population limitations here. The fair number of states said, yeah, okay, let's open the doors to family caregivers at least in this time of emergency. And so what's going to happen next? And we don't really know, of course. States do have the option to extend their extended case just for 6 months after the expiration of the public health emergency, and many have already done so. So that we can see that, so for example, and this is where things get a little, why I pointed it out, North Dakota is listed as one of the states that has already has already asked to extend its extended care authority, and that's because North Dakota added it as part of their developmental disabilities program. So the number of states are already looking in that direction. And CMS has provided some guidance to say to states, okay, if you want to go there, here's some things you might want to think about if you're submitting a permanent waiver amendment. So that the public health emergency isn't over yet, but that you can kind of see it from here. So that for states that want to think about extending these authorities, they probably want to start thinking about it sooner rather than later, because you've got 6 months, and we all know the amendment process takes 6 months if the gods are with you. So the time is really crunch time for states now to be saying, okay, I've got this new authority, do I want to keep it? And I think that for folks who want to play an advocacy role, this is a good time to be doing that. And that said, I will stop with that in my talking fast mode and turn it over to Ellen to talk about some really fun stuff. Thanks.
Hi, everybody. Thank you for being here. Thank you for having me. And I'm happy to share my experience talking with participants and caregivers about why this option is important to them and why. So Casey, can you fix that slide?
Does that look good for you, Ellen?
Okay, yeah, I was seeing part of the next one. Okay, so Lori and Merle have done a really nice job with what we already know. And I will just, by way of background, summarize quickly that self-direction is an empowerment model, and the idea of choice and control has been essential to the design and implementation of the program and the experience of people that are in it. And as Lori mentioned, self-direction resulted in fewer unmet needs and satisfaction both for participants and caregivers in the cash and counseling demonstration evaluation. But it's important to note that there still were unmet needs. And some of them might be addressed by this option. And hiring family caregivers has the potential to really support person and family-centered care, which has been a major push and advocacy by the AARP Public Policy Foundation. Supporting family caregivers is a national priority. We know that from CARI, from the current RAISE Family Caregiver Act, and hiring family caregivers, we have some indication is a way to support them in their critical role. Paying family caregivers, as we've learned, is grounded in history, in research, in debate, and in evolution. So in this presentation, what we sought to understand was how important is the option for paying family caregivers to participants and to family caregivers. And I think this information has implications for program development and improvement to generate recommendations to improve access to paid family caregiving and also to support paid family caregivers in this role. So what I did for this presentation was I looked at data from 3 separate studies. They were all qualitative studies looking at the experience of both participants and family caregivers in participant-directed programs. The Voice of the Veterans included veterans and caregivers who were in the veteran-directed program. The experience of diverse caregivers in self-directed programs. We interviewed a pretty large number of family caregivers of people with a full range of ages and disabilities. And then recently the VA has conducted a evaluation of the veteran-directed program, of which there was a qualitative arm asking people about how they access the program and their experiences within it. So for all of these studies, participants were recruited through the state waiver programs or VA medical centers. And that's important to note because this was not a random sample. This was a convenient sample of people that volunteered to participate in interviews. We used semi-structured telephone interviews. And the interviews were not asking them specifically about paid family caregiving, although that did come up with some regularity. We asked about their experience enrolling and participating, how self-directed programs impacted their lives, and what kind of improvements could be made. The interviews were recorded, transcribed, and analyzed qualitatively. So this is a secondary analysis of data viewed through the lens of paying family caregivers. What it means to participants, what it means to family caregivers. And so I summarized these with a few overarching themes with some exemplifying quotes. Trust was huge. Trust came up a lot. I don't want a stranger coming into my house. Ultimately, what you really want is someone you can really trust, who'll give you 100%. I like to know that my wife is being taken care of properly. It eliminates worries, like are they going to show up? Who's going to show up? Are they going to know what to do when they get here? Another theme was knowing or being known. And this came up both for participants and also caregivers who talked about how important it was to have a caregiver who really knew the person. So a daughter said, it was extremely important to me, especially with my mother and her mental challenges, to not have a new face coming in the door every day. I had to have the consistency because that cued her behavior and everything else. I mean, if she saw the face, even though she didn't know the name anymore, she'd recognize them. She was calmer. She was more cooperative. Another theme that I thought was totally awesome was the idea of reciprocity. For a participant who is receiving care, the ability to get back, and this is specific overall to self-direction, as well as to paying family as caregivers. But I think it's helped a lot with my wife too, because it's taken a lot of stress off her. You know, it just makes me not have to worry. I mean, my wife helped too, but I honestly believe that she should get something for that, because even though my wife loves me, I know it's hard on her, and I don't want her to lose interest in me just because I'm getting old and think I'll just put him in a nursing home somewhere. And by her receiving some money for her time, it kind of makes her feel like she's important also. And finally, for the participants, the theme of dignity. And this quote is from a man who described himself as being really down and out, depressed, even suicidal. And he actually hired his ex-wife to be his caregiver. And so these are his words, talking about himself. Now, all of a sudden, he's got some responsibility. He gets to hire somebody. He gets to pay somebody. He gets to thank somebody and say, you've done a wonderful job, and smile again, because the person that's coming through the door is a good family member. So that's being a man again. I love that thought of giving the veterans a chance to be a man. Being paid as a family caregiver was also important to the family caregivers themselves. The commitment to giving good care was so pervasive through the interviews. And this wife was talking about how being able to be there and be with her husband really enabled her to take good care. I'm going to notice when his breathing's not right. When something's wrong with his speech, his physical, maybe somebody else wouldn't notice. I can pick it up a lot faster, and that quick response time is really important. Several occasions in the last year, I was able to notice something in the very beginning. We've been able to save him several trips to the hospital just alone in the last year, and we've also been able to prevent several falls. Family caregivers were also committed to supporting the participant goals. I'm able to keep him home where he wants to be. This one speaks, as Lori mentioned, from the research about improved quality of care. The caregiver says he doesn't get sores at home, scrapes at home with me taking care of him. Family caregivers also reported decreased stress. Now I don't have to work out of the home just to make a living. I can be at home, take care of him. The stress relief they experienced came in a number of ways, such as the example to pay other family members to help with caregiving and the added scheduling and flexibility. One man talked about hiring his grandchildren and was so proud that he was going to be able to put this toward a college fund. Another caregiver said it just took the pressure off. Like I had a big pack on my back. It just like slid off. And caregivers also spoke of reciprocity. It gives us as a couple more time to spend together. A woman taking care of her grandmother said, she took care of me, and now I take care of her. And several spousal caregivers described how stress relief for one partner impacted the stress level of the other partner, which again was a reciprocal benefit. And there was one particular example I can think of where the wife was working outside of the home, the husband was confined to a chair while he's home. She spent her time at work worrying about what was happening with her husband. He spent his time at home worrying about what was happening with her wife and how much stress there was for her to have to work and then come home. There were also challenges that were faced by paid family caregivers, and I think these are important to consider and to think about what might be done to ameliorate some of them. A major one was isolation. As one person said, but you do take a loss to your personal life, you know, because you don't have time to establish a relationship with anybody or spend time with friends, or you separate yourself from the caregiving. Another caregiver spoke about, although she was really happy to be a paid family caregiver, she really missed interacting with the people at work and the intellectual stimulation. Another challenge was access to support. Some of the caregivers told us that whereas the participant had access to the supportive resources, and it's interesting, I think, because self-direction by design is an incredibly supportive network of resources, and caregivers wanted to have access to them. As one man said, they only look at the half of the unit, you know. They don't look at, okay, there's 2 people living in this house, but we're only going to help out one of them. The other person is also affected by what's going on. It was interesting what Merle said about the availability of respite. Finding respite was difficult for a lot of the family caregivers that I spoke with. Both finding somebody who had the knowledge and skills, finding somebody who would come for the amount of pay that was available, feeling that spending money on respite care took away from the hours of care. Anyway, it was still something that was really needed by a lot of people. We'd like to have someone who's familiar with the memory loss, the mobility issues, being able to cook a meal for her, you know, all those sorts of things. And I don't know that those kinds of substitute caregivers exist. And finally, the issue of choice and career implications came up as challenges. And with choice, I put both positive and negative, meaning some people wanted to be paid family caregivers. As Merle said, so many people were supportive of the idea and gave their reasons, but they were prohibited from doing so by the program they were in. On the other hand, and I know this came up in the Home Alone Revisited study, that there were caregivers who felt they didn't have a choice, but that they were put in this position. And in it, they were pleased to be paid, but the issue of choice did come up, and career implications. One woman said, after my person dies, what am I going to put on my resume? That I was a caregiver for 30 years? And so finally, some of the implications and recommendations that I think evolved from these qualitative experiences of the people in the program, expanding access to the option to hire family caregivers. I think for many reasons that, including those mentioned by Lori and by Merle and by the participants and family caregivers, expanding access is a recommendation. I know that AARP Public Policy Institute has been very active in terms of person and family-centered care and really upping the use of family assessment. Not just what can you do for him, but what do you need. And I also put in over the trajectory of caregiving because many people felt that they had some information and resources at the beginning, but things change over time. And so being able to be dynamic and responsive to changing needs and also particular challenges that were faced by many of these caregivers. And then finally, to expand access to program supports, such as the support broker or options counselor, FMS, to family caregivers. And the examples where people felt that they had that support were extraordinary, and just more people wanted it. And finally, I'd like to acknowledge the funding that we had for these studies, for my appreciation for the veterans and caregivers who participated in the research, of course, all of the team of people who were involved in these studies, and then all of you for your service. Thank you. And now I will turn things over to Carrie.
Great. Thank you, Ellen.